For chairing this session, we have Professor S.K. Sinha. He's Professor of Gastroenterology at PGI Chandigarh and presently in Dhaka. And we also have Dr. Abdul Khaliq, who is a consultant gastroenterology at the Umda Healthcare in Hyderabad. Over to you, chairpersons. Your video is visible.
Okay, for the next session, I invite Dr. Shaji Sebastian, who is consultant gastroenterologist and professor, director of the clinical studies at Helen York Medical School, UK. He is authority in IBD and has lots of work done, published lots of papers in the perspective of COVID, also in the setting of IBD. Dr. Shaji, please. That's better.
This is take 3. So I'll go through these 3 particular areas. What have been our challenges for the last 1 year, and how did we use data by the extraordinarily collaborative effort to understand some of these challenges, and also touch upon the hope which is in the horizon in relation to vaccines. COVID is still very much in our midst, particularly in Europe and North America. There have been more than 1 surges, and there is also an indication that there may be a further surge coming in some parts of Europe. Fortunately, in the United Kingdom, I should say in India, it appears to be tailing off. So what has been the challenges right at the outset? In March last year, we found that there are challenges in resources, delay in access to care and tests, delay in treatments, and to capital, increasing patient concerns. The graph on the right shows the exponential increase in the contact by the patients to our IBD helpline, which is manned by the IBD nurses, soon after the onset of COVID in the UK at the beginning of March. The main concerns were related to the risk of opportunistic infections, which previously has been looked at various therapies for IBD. But we have to remember that these opportunistic viral infections with thiopurines and anti-TNFs were mainly DNA viruses, and COVID, as we know, is an RNA virus. So right at the outset, we were looking for clues from the past, but sadly we did not have a great deal to bank on. There were no real lessons from the past, from the previous SARS epidemic or the MERS epidemic, because none of these epidemics had papers which looked at IBD or other immune-mediated diseases. We had to go then back to the bench and look at how the immunopathogenesis of COVID-19 may have relevance to IBD therapies. And in this particular cartoon, you can see a number of cytokines which are involved in IBD and its management, and also in the clinical manifestations of COVID-19. And hence we extrapolated at that stage based upon the mechanism of action of various drugs, and postulated that it may well be that some of our IBD drugs is unlikely to have any deleterious effect. This was way back in April 2020. And we proposed at that time in this paper that it would be a tug of war between coronavirus and host antiviral defenses in association with the protective or deleterious effect of IBD drugs, which will determine the outcomes. Similarly, there were concerns in relation to IBD surgery. The early data from the COVID surgery, which is not specifically to IBD, suggested that there may be a very high 30-day mortality in patients who are undergoing surgery with COVID-19. And similarly, there were delays in cancellation of elective surgery, particularly pertinent to IBD patients, and this was another concern. So there were lots and lots of uncertainties at the outset. And how did we overcome some of the challenges and what were the data which helped us to do that. And this is hugely thanks to a number of large-scale collaborating research studies, which some of which I have detailed here, including the Secure IBD and the ongoing Clarity IBD, which is giving us data on a weekly basis to improve our understanding and prepare for any future surges. First of all, let's just go back to the baseline. This is a paper which we looked at, in which we looked at our own service, how we had to react to the challenges which I detailed above, and reset our service with the hope of restoring back to our baseline services later in the year, although the restore phase is still going on due to the challenges of the various surges. We had to make structural reconfiguration in our IBD services, moving pretty much exclusively to virtual care, moving the infusion unit to a site away from the hot acute hospital, and also conducting meetings mainly virtually, as like we are doing. And it was really gratifying to see that both the healthcare professionals as well as the patients found that implementation of virtual clinics in the inflammatory bowel disease setting is at least as good as face-to-face in a significant proportion of respondents. What about the incidence of COVID-19 in IBD patients? To me, the best study on this is this Dutch cohort study, which included the entire Dutch IBD cohort and compared with the general Dutch population, and found that the incidence of COVID-19 infection is identical almost to the general population. Similar messages were given from the two US studies, the VA study and also the Northern California study, where the population weighted prevalence was identical to general population. Vishal and colleagues did this excellent systematic review published in UEG journal, which clearly indicated that IBD patients have similar risk of acquiring COVID-19 infection. So in summary, the incidence of COVID-19 infection in IBD patients is similar to general population. What about the risk of serious COVID-19 in IBD patients? And to me, the best data comes from the large Secure IBD database, which I'm sure there are patients being included from India as well, which has so far included just over 5,500 patients. And in the latest data cut on mortality, the overall mortality in IBD patients is 2% in the entire cohort. And you can see that majority of the deaths have happened after the age of 60, thereby suggesting there may be other confounders, including age, which is mainly accounting for mortality. The study which I detailed earlier from the Dutch cohort also suggested that there is no difference in relation to mortality in the IBD population when compared to general population. What patients and perhaps also the healthcare workers have been increasingly concerned about is the risk of the therapies what we are using in IBD during the COVID period. Again, coming back to the Secure IBD data set, this is their first paper which they published at the tail end of last year, including just over 525 patients. And there were early signals that systemic corticosteroids and 5 ASAs may be related to adverse outcomes in COVID-19, and here they define the adverse outcomes as the need for hospitalization, ICU stay, or mortality. But what was important also to see that the rest of the medications, including biologics, were not associated with any adverse COVID-19 outcomes. However, in their subsequent paper published in Gut earlier this year, they kept the baseline of TNF monotherapy as their reference. They found that monotherapy with thiopurines, or indeed combination therapy of anti-TNF with thiopurines, may be associated with increased risk of serious COVID-19 outcomes. Now, the biggest problem with the secure IBD registry is the case ascertainment and inclusion biases which are inherent in any large multinational registry studies, but nevertheless it gives some signals that TNF therapy is safe, but perhaps thiopurines may be causing additional risk. However, when we looked at prospectively in the UK in a large multi-center cohort study from March of last year, and this is just in press currently, we did not find that even steroids are associated with increased COVID outcomes. Now, what is the likely reason for this difference is that the social distancing and also shielding guidelines which have been submitted through the UK authorities to patients indicated that perhaps the overall COVID risk in these patients were somewhat smaller. Vishal and colleagues' systematic review again conveyed similar messages. This was done earlier in the pandemic, which suggested that the one drug which perhaps may be associated with worse outcome was corticosteroids. What about the impact of IBD activity on COVID-19 outcomes? The data here is somewhat sparse, I should say. The first paper in Gut from the Italian group suggested that active IBD may indeed be a risk factor for COVID-19 related death. But if you actually read the full text of the article, they only had 6 of their patients with active IBD, clearly a confounder in their analysis. The secure IBD data, which defined the IBD activity purely based on physicians' global assessment, appear to be suggesting that severe activity may be associated with worse outcomes, but this is currently an unpublished data. Again, coming back to our own study, we looked at IBD activity in a more granular fashion, including endoscopic criteria, biomarkers, and clinical symptoms. And we have not demonstrated what has been so far considered to be an adverse risk factor, which is IBD activity. This is also further evidence. Admittedly, this was not the primary outcome measure in our acute severe UC study, in which 253 patients of our acute severe UC were tested for PCR for COVID-19. We only had 2% positivity rate, and none of them had serious COVID-19 outcomes. Now, going into the surgery, the data on this is evolving. Our own data from the PREPARE IBD study is still awaited, but I can share with you that there was clearly reduction in laparoscopic surgery rates compared to the control group from the previous year, mainly driven by the concerns about the potential for postoperative leak requiring the use of ICU, which was passed due to ICUs being taken over by COVID-19 patients. But what is available is just published from the COVID surge group, in which they have identified that patients who do have COVID-19 at the time of planning for surgery, it is better to wait at least a period of 7 weeks after the diagnosis of COVID-19. So in summary, there is no increase in COVID-19 adverse outcomes with the use of conventional drugs for IBD, except what I would currently call as caution with use of steroids. Let me move on to hope. And I'm sure all the researchers in this meeting would love to have one of their papers which is showing as clear separation between the two graphs which are shown in these slides in relation to SARS-CoV-2 vaccine. It's an incredible result, got at an incredible speed by the community as a whole of researchers. We have published the guidelines for patients from the British Society of Gastroenterology and IBD Clinical Research Group position statement, mainly recommending strongly SARS-CoV-2 vaccination in all patients with inflammatory bowel disease. In fact, actually taking precedence of vaccination over treatment at a given point. Similar message has also been given by the IOIBD, which has been subsequently published. We keep very regular contact with our patients through the Crohn's and Colitis UK, and similar ventures are available across the world with the patient charities actively promoting vaccination. The vaccinations are proceeding at pace. However, we do need to vaccinate the whole world to put an end to this pandemic. What is the data from our own? Vast majority of our patients, close to 98% of our biologics immunomodulators patients have already been vaccinated with their first dose. And because of UK regulations, currently the second dose is being postponed up to 12 weeks. And so the current second dose numbers are much smaller. Do we have some concerns about vaccine response in IBD patients? To be honest, yes. And this is what we know from the literature, that with flu vaccines and other vaccinations, patients on immunomodulators or anti-TNFs may have some reduction in seroprotection, maybe even up to 25 to 50%. Hence, we wanted to look at this quite early on, and that is why we have set up this large study which has recruited over 7,200 IBD patients on infliximab and vedolizumab over a 3-month period across the whole of UK, and currently the analysis of this has been going on. We will be providing data. Look out for this over the next 7 to 10 days of some of the papers relating to this, particularly in relation to the persistence of anti-SARS-CoV-2 antibodies with confirmed COVID-19 infection stratified by biologics, and in addition, the antibody response to vaccinated patients who have been treated with infliximab or combination therapy compared to a reference standard of vedolizumab, and in the near future also T-cell responses to vaccinated IBD patients. So look out for that over the next week or so. We do have lots of unknowns. What is the impact of the immune hit by COVID-19 in IBD patients? We do really need to study more in detail, and there are studies certainly going on in the UK and I'm sure elsewhere, the psychological impact on patients, but also on the healthcare professionals, you and me, who had to navigate through the last 1 year period. We don't know much about long COVID in IBD patients and many more other questions needing answering. So let me conclude by saying that preparing for COVID surges so far in IBD care has given us new experience, both for IBD patients and IBD teams, and we were confronted with many practical challenges and concerns about the risk of IBD drugs. The fast pace of collaborative research has allowed us to find that IBD drugs in general are safe to use and maintain, and prospective data is evolving. And we have hope in the horizon with IBD patients being vaccinated at pace, and we will be soon getting vaccine response data, IBD available too soon. I earlier listened to the talk on acute severe UC, so I couldn't but not forget to put a cricketing theme onto this. Now, this is actually in last year in the ICC World Cup, and this is in Birmingham in the UK, and the attendance was Indian supporters were 71%. England supporters were a mere 22%. I don't know what this chap is doing when Rishabh Pant is being caught here. Maybe he had some identity crisis. I certainly do not have identity crisis, and I want to continue this collaboration with my colleagues and mentors in PGI. Thank you.
Thank you, Dr. Shaji. I think we will not be able to take any questions, as Dr. Vishal is hinting me. We are much behind the schedule. So I think close the session, and thank Dr. Shaji for very elaborate talk and discussion and showing lots of data. Thanks, Dr. Shaji. And I hand over the proceeding to Dr. Vishal.
Thank you so much, sir. Since we are running pretty late with